Welcome to Times Conversations. Times Conversations is a platform that the Times of India has created for knowledge exchange with leaders and pioneers in Bangalore. I'm Sujit John, and I'll be hosting this conversation today with two renowned doctors at Gunasheela Surgical and Maternity Hospital in Bangalore. Infertility has become a growing concern among youngsters across the world, including in India. Lifestyle factors, environmental factors including pollution, delaying decisions to have a child, these are all reasons why we have a serious and growing infertility problem among both men and women. But equally, there are excellent treatments emerging to deal with the issue. Gunasheela Hospitals, which turns 50 this year, has been pioneering some of these techniques. Gunasheela was founded in 1975 by Dr. Gunasheela and Dr. Sulochana Gunasheela, whose passion for reproductive medicine led to the creation of this institution. The center achieved a remarkable milestone with the birth of South India's first IVF baby on December 5, 1988, forever changing the landscape of assisted reproductive technology in the region. What started as a small clinic has now evolved into a premier fertility hospital recognized both nationally and internationally. Over these 50 years, Gunasheela has seen nearly 5 lakh OPD consultations, and has treated more than 2.7 lakh infertile couples. The institution today is led by Dr. Sulochana Gunasheela's daughter, Dr. Devika Gunasheela, and her husband, Dr. Rajsekhar Nayak. Infertility specialist and obstetrician with over 3 decades in the field. She is the managing director and senior consultant in IVF at Gunasheela Surgical and Maternity Hospital in Bangalore. Dr. Rajsekhar Nayak, as I said, is a renowned laparoscopic and bariatric surgeon with over 37 years of experience. He serves as a director at Gunasheela Surgical and Maternity Hospital in Bangalore. In India as well as globally, infertility issues growing. Just trying to understand what is the reason, why are youngsters having this problem today?
Yeah, I think basically the total fertility rate in India itself has decreased from, shall we say, I think something like about 6.8 in 1950s to about something like nearing 2 at this point of time. Now, apparently, if the fertility rate decreases to less than 2, then we have a problem because the generation is not getting replaced. Yeah.
So population is declining.
Population is declining. Now, the reason for, I think, a decreased fertility rate amongst youngsters can be classified into societal changes and behavioral changes. Societal changes would be the fact that women are getting more educated, they are employed in good companies, they are climbing the corporate ladder, they have the freedom to choose their partners. They also have the freedom to choose when exactly they want to settle down. And sometimes even if they are married and they found the ideal partner, they may not find it very, shall we say, conducive to have a baby at a particular point of time. Lifestyle changes would include eating out, smoking, alcohol, ordering from outside, and there's plenty of it happening. Like for example, we drink water in plastic bottles. Now the plastic leaches out substances called bisphenol A into the water, which is actually what is called as an endocrine disruptor. That endocrine disruptor is a substance that bisphenol A will produce inflammation in the ovaries and in the testes, thereby decreasing the quality and the quantity of eggs. So people are eating out, they're using preservatives, drinking from plastics, coloring agents. Also, along with that, we have so many pollutants in the air. We have dioxins from factories and the likes of it. For example, if you order something from outside, it comes in a container. So hot food is put into that container, and that again produces leaches substances toxins into the. Again, you have pesticides, which you can't do without. There is a decline in the quality of eggs that are coming out from women. So after the age of 35, women start to find that it is more difficult to get pregnant. They have a higher rate of miscarriage, and they have a higher rate of producing slightly abnormal babies. Okay. So that's a natural decline. And in our country, we are seeing that more often. And I see patients who are at the age of 32, 30, coming in with low ovarian reserve. That means the stock of eggs in the ovary is declining. And it's very sad because they have just gotten married, they got married at 31 or 32, and they come in saying, I just want to get myself checked just to see if everything is okay. And then you have the situation where their stock of eggs is kind of completely in their shoes, and it's a shock for them, it's a shock for us, but we're seeing more of that type.
The more educated the woman is, the more she can make a choice of when she will get married or when she will have a child, at what age and when. Now, like we discussed just now, delaying childbirth or delaying pregnancies also can be counterproductive. If they leave it for far too long, then they have a problem with conception. That's the first thing. Second thing is, we see this trend nowadays of not having a child. Some people get married or they live in and they say, we don't want to have children. Now, that's fine, it's very fashionable and all that, but what happens is, over the years, when their colleagues have children and when they reach their 40s, when they go to social functions and places like that, all their colleagues are talking about is their children, because that's the most exciting happening in their family. Whereas this couple who decided not to have children feel left out. And then they feel that, oh, maybe we should have had children in fact.
But if a woman is trying to climb the corporate ladder and does not want to take off and things like that, there is an option of egg freezing, which she can opt for.
Okay.
She can freeze her eggs and then she can maybe use them at a later stage, because I have had women who come in at 42, 43 saying that, oh my God, I wish I knew this option was there. And now it's too late because we're not able to get any eggs from her. Quality of the eggs, the quantity also comes down. See, the thing is that every woman is born with a certain number of eggs, which is a fixed number. You can't change it. And every cycle, when a patient goes through a menstrual cycle, an egg is released, but to release that egg, thousands of eggs are destroyed. So it's a continuous decline in the number of eggs. So the stock of eggs comes down. And then by the time, at least for Indian women, by the time they're reaching 37, 38, they are, in terms of biologically, they are getting old in terms of their reproductive potential.
So the age of the egg will be at what time it was taken out of the body.
What time?
At what age? Suppose she was 27 when the eggs were taken. So the age of the egg is when that woman was 27 years old. She might choose to have a baby at 35.
Okay.
But the quality of the egg is at 27. So the quality of that egg is better. The chances of pregnancy is better. The chances of having an genetically abnormal child is less. Yes, you can freeze sperm.
You can freeze sperm.
Yeah.
But men are quite lucky, you know. They've always been lucky.
Why is that?
Because I feel that they kind of, can reproduce till they're 50, 51. It's only after the age of 48, 50 that they actually start to get some changes which can actually be transferred into the baby. So they have a lot more time.
It's not in the woman. In woman, attains menopause by about, let's say, 45, 50, 55. So about 5 to 7 years before that, the egg quality starts deteriorating.
These technologies where you can grow the baby in a lab and all that, those technologies have really improved over the years. You were one of the pioneers in doing an IVF baby in 1988, I think. Since then, before this started, we were discussing it, and you said the success rates were much lower than then, but it's significantly higher now.
So in 1988, when we got our first pregnancy, our pregnancy rates were hardly reaching about, shall we say, 8 to 10% at that point of time. And that was upsetting my mother hell of a lot, because she thought, because the West hospitals, and also what happened was that they went to a pharmaceutical company where there are a series of filters which filter the air and push purified air into the lab.
Dust, atmospheric dust and pollutants are not a huge issue in the Western world, because their air quality is much better. Dr. Sulochana was not getting the results that she was expecting or compared to the Western countries. At some point she realized that this could be a problem. And we did visit some centers and they were having it on the top of a bus stop or some open building, all the IVF labs. But they have no dust in those countries, some of those countries. They're so clean and they don't have a problem with uninterrupted power. So these were two huge challenges. So what Dr. Sulochana did was she brought the concept of a clean room where air is pumped in through HEPA filters, with almost zero dust in the lab. She borrowed this concept from the pharmaceutical industry because there's nobody to follow in India. This didn't happen in India, it was not happening abroad. So she thought of it, she had some friends in the pharmaceutical industry, she went and visited that place, saw how these things are done, and then we put up our lab with a clean room. It's called the clean room now. There are various standards for clean room, depending on the size of the particles that, and now every IVF center should have a clean room. The art bill mandates that you have a clean room for a, yeah. So after that, the success rate just jumped from 7-8% to about 30-35%. Yeah.
The instruments that we use, the microscope, to look at the oocytes, to assess the quality, to inject the sperm into the egg, to the media. Media is another very big point, because you see, the sperms and the eggs have to be cultured in a media.
It's a liquid where they grow.
Liquid, which and also the incubators are certain special instruments where you keep the egg in the media at a particular temperature, pH, humidity, etc. Controlled conditions. The incubators have improved. The media has improved, and it's very important that the media is stored in a cold chain.
International companies, mainly because of they're expensive, but we are assured of a certain quality. And IVF being an expensive treatment, maybe some couples can afford only one shot at IVF. So what we believe is they should get the best chance. And we don't want to experiment on using locally made as of now. Yeah.
Yeah, but to a large extent, media is still important.
Okay.
Yeah.
Okay.
And of course, the drug quality also has become better. Before, when IVF was started, they used to use drugs that were made from the urine of postmenopausal women. You also get drugs from recombinant technology, which is supposed to be the best that you can actually get right at this point in time. So like that, there have been various reasons for the success rates to have gone up.
Recombinant technology, can you explain that?
It's made from the Chinese hamster cell line. There are a lot of genetics involved in that, and then from recombinant technology, they make that drug.
You also do some research.
And also, it is the quality of a lab. So we have very, very stringent quality checks and audits. So suppose at one point of time our pregnancy rate goes down, everybody is called. Starting from the doctors to the embryologists to the ultrasonologists. We have audit meetings and we try to see what went wrong, what drug was we using, what happened in the lab, who did the transfer, etc., 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 and try to troubleshoot. So that happens on a regular basis with us. And we've also taken it a step further to try and see whether these embryos that we are putting in are genetically normal. For a pregnancy to take place, the embryo contributes 75% and or 70 to 75, and the uterus contributes about 25 to 30%. So embryo is the main structure. So an embryo may be good in the sense of its division patterns, the way it's looking, cells are regular, everything else, looking like a beautiful embryo, but it may be genetically abnormal.
Of a center depends on multiple factors. Obviously, the most important is the patient, and it's the combination of the patient's biophysical profile, the doctors who are treating the patient, as to what drugs you give, how you stimulate the patient, and the embryologist who works in the lab. The embryologists are the people who mix the egg and sperm, inject and do all that, and the quality of the lab. So all the three will play a very important role in the successful outcome of a pregnancy. It's a central government, it's an accreditation. So when Dr. Sulochana was thinking that there should be some form of accreditation to the work that we are doing, she again borrowed something from the industry called the ISO standard. So she borrowed that from the industry, which is not, it's a manufacturing standard. So she borrowed that and implemented that into IVF. So these are all very pioneering things that she thought of and brought it. So that again helped us in our processes in terms of let us the turnaround times for the media to come, the pH, the conditions in the lab, the clean room quality, which has to be, we do a dust check and a VOC check every 3 months. So all this has to be done because you're an ISO certified organization.
And every 2 years we have a big audit where either you pass or you fail. So So we've been passing the last so many years. So that way it's, it's really good. And then we started our genetics lab, didn't we?
And
Yeah,
like I
so
said,
what
the
was the
quality of the eggs and sperm. Now there are various ways to see how good the sperm or egg is, and that will ultimately decide how good the embryo is. Now there are ways to grade this. There are international standards where you grade the sperm and you grade the egg, and you need a very good embryologist to grade them. As of now, AI is just coming into that space, but as of now it is completely dependent on the embryologist, and the more experienced the embryologist is, the better is their grading, and therefore better is a successful outcome. That is one aspect of that is a morphology as you see it under the microscope. That is one way of assessing the egg and the embryo.
No, for a good pregnancy rate, you should get about somewhere between 10 to 15. That's worldwide, if you look at your journals, that's what they say. Shall we say 15 eggs? You will not get 15 embryos. Very rare cases, you will get 15 embryos. Very, very, very rare. So it's always a reduction. So the number of, once you inject the sperm into the egg, so will they fuse? That is called fertilization. Then if they fuse, will they divide? Okay, so from 1 cell to 2 cells, 2 cells to 4, 4 to 8. When they reach 8 cell, that is on day 3. The embryo has reached that cell stage of 8 cells on day 3. Now from day 3 to day 4 is a huge jump in an embryo's life. Yeah, and a lot of embryos don't do that jump. They don't make it on the other side. So a lot of embryos get arrested, and that's mainly because the embryo starts to use until day 3 is using the maternal sources of energy. That is, the maternal source of energy is the energy that is in the egg. From day 4, it has to use its own energy, and all the maternal DNA content, etc., should all go away. Everything, about maybe 90% should go away. Maybe 5 to 7 or something can remain. If more than that remains, the embryo will arrest. So finally, if a woman has 15 eggs, she will not end up with 15 embryos. She will end up with maybe 7 or 8 or 9.
The quality of the embryo, one is, like I said, you look at it and you say, okay, this is a good embryo, this is not such a good embryo. When you look at it, that the embryologist will decide. The second way of looking at it is, these are all advancements, is how the embryo functions. How much time does it take to divide into 2 cells, 4 cells, 8 cells? How much time does it take? So there are fixed rules for that. If it is a good embryo, it divides into 4 cells in this much time, 8 cells, morphokinetics. So there is a technology called embryoscope, called the time-lapse system. What it does is, it takes pictures of that embryo every 15 minutes for 48 hours, and then it makes that into a small video of, let's say, 1 minute. That's a video. You can see the cells dividing. You can actually see the beginning of life. So that is a morphokinetics. That will also tell you how good or not good the embryo is. The third aspect, like we were just talking, is the genetic quality of the embryo. So these are 3 different ways where you can assess the embryo. One is how it looks, one is how it behaves, and the third is what is its genetic quality. Now all these have got very important, it's got very important impact on the chances of pregnancy.
At what stage do you put the embryo into the woman's body?
There are 2 ways to put it back in. One is what is called a fresh transfer, which is when you stimulate the patient's ovaries and then you make the embryos and you put it in on day 5 after the embryo has reached day 5 with all the various hormonal supports. Or you can do what is called as a frozen embryo transfer, where you grow the embryos up to day 5, and then whichever are the best ones you will freeze. And then you ask the patient to come back, ask her to have her period again, and then after that she comes back whenever she is psychologically and mentally and physically ready. And then again we prepare the uterus and the lining of the womb with some medication and then put it in again on day 5. When you talk about genetic abnormalities that these genetic tests can actually look at, it is basically a numerical test, because for example Down syndrome, which results in a mentally challenged baby, has 3 chromosomes instead of 2 on chromosome 21. There are 3. When actually every chromosome 1 to 22 and the sex chromosome should only have 2. So you have 3, so you have 47 chromosomes instead of 46. You can also have monosomy. So basically we have disomy. Disomy means every chromosome has it's a pair. So trisomy is 3. So you can have trisomy 21, which is Down syndrome, trisomy 18, which is Edwards syndrome, trisomy 13, which is Pata, so are the most common ones. Our genetic test, what is called as PGTA, that is pre-implantation genetic testing. That means even before you put it into the embryo and it goes and gets implanted, which is the embryo getting stuck inside the uterus, you are actually doing a genetic testing and you are trying to find out whether there are any abnormalities or not. So that is one aspect which you are looking at, all these numerical chromosomal abnormalities. We've had patients who have had 3 babies that have passed away. So then what you do is you examine the mother and the father. So they would have come with some kind of a diagnosis. They have shown the pediatrician and they have come with some certain diagnosis. We ask them to go to see a genetic counselor. We have a genetic counselor with us. And then he comes to his own conclusion. Then the tests are done for the parents to see whether they are both carrying the same faulty genes. Then we assess whether that has actually, what was the probability of that having gone into the baby and produced a problem. And then we ask them to come for an IVF cycle, where we take the eggs and then mix the sperm with it. And then with the resultant embryos, we will again take out cells and check and see whether that particular chromosomal abnormality that might have been present in the babies that have passed away is there or not. And if those embryos have that problem, we don't use them. And if they don't have that problem, we put them in, and it is called as PGTM. That means pre-implantation genetic testing for monogenic disorders. That means we have billions of genes. So in that one particular gene is that problem there. But we will not be able to, in this kind of a testing, we will not be able to identify a baby that has a hole in the heart, because ordinarily testing it, just doing a PGTA, which is looking at numerical abnormalities, you can't pinpoint certain specific disorders. Whereas if there is a history of a problem in the family, then we can test the parents and see whether that gene is being transmitted into the.
For example, there is a disease called sickle cell disease and thalassemia, which can happen. It's a blood disease, and then the children suffer from a lot of problems during their childhood because they are anemic. Their sickle cell, their cells, when the oxygen levels fall, the red blood cells become crumped and become sickle shape, and they're not. It's a genetic disorder. And genetic disorders, there are 2 things. One is that you can have a carrier state where the person himself carrying the defective gene doesn't suffer from the disease, but can transmit the defective gene. Suppose both the couples have got this defective gene, then it is possible that both of them give the defective gene to the child and the child will become a sufferer of the disease. Now, we had a couple where both were carriers for sickle cell, and then we offered them IVF, and then they got 13 embryos, 12 of them which had the defective gene and 1 did not have the defective gene. And we used that gene, that embryo, and they had a girl child free of that disease.
Really?
Yeah. And future generations of that little girl will not have that defective gene forever. So that defective gene is eliminated from that family.
Unless she gets married to somebody again.
Somebody else has got,
Yeah,
Yeah.
exactly.
Yeah.
So that is the technology, and we have it in-house. We have our own genetics lab headed by very senior scientists who are advisors, and then they run the show for us as far as the fertility genetics is concerned. A sperm sample and an egg sample is tagged with RFID, and the patient is given the RFID card. So the patient comes to the hospital with the card, and that card is put into a slot inside the lab. So as long as that card is there, only those 2 samples will work.
Okay.
Any other sample brought into that vicinity, you get an alarm.
No, the system shuts down.
And yeah, the workflow stops.
Are they still generally rising, or is because of technology that you have to pay for those kinds of technologies?
Yes. Genetic testing is very, very expensive.
Very expensive?
Yeah.
That embryo?
Yeah, it is expensive because the genetics, well, I think if we had known how expensive how expensive it was to run a genetic lab, maybe we wouldn't have even ventured into it.
Really? It's that expensive?
It's very expensive. So everything that you touch is in lakhs only, it's not in thousands.
All imported stuff and all.
Yeah.
There are people who make these sequencing machines. This genetics is basically about sequencing your chromosome.
DNA.
So DNA. So both these technologies are from the US. There are only 2 companies in the world, and both are from US. And their technology is expensive. the reagents, the kits, what they call them, they cost lakhs of rupees. And so those tests are, so we don't apply these genetic studies to every patient that walks in. No.
You give them the option or?
Then every patient doesn't need it.
Doesn't need, yeah.
Yeah,
Okay.
you would only use it for certain.
History or?
Yeah, like I said, like a history of baby is not doing well, so that is PGTM. Or women who are old, we are trying to do something called as Thai Bhagya, which is a program where we're trying to give it at a low cost without compromising any of the steps that we take and without compromising the results. So. That is for, shall we say, the slightly underprivileged section of society.
They'll have to come to the hospital, half a dozen times. And then each step is like an exam. First of all, when they come for the initial screening, whether she can have enough eggs. Then when the eggs, how many eggs did we get? How is the husband's semen quality? And have the eggs fertilized? How many embryos have we got? So every step is like, so at every point, a detailed counseling session happens.
And we believe in telling the patient upfront, okay, we lay all the cards on the table and say no false promises are given, because there are no false promises. And this is what the capacity of this treatment is. And you have to understand that. And then, and this is how much it's going to cost.
Yeah.
And we're going one step further to, like, we get people, try and help women get pregnant. We handhold them to their pregnancy. And now we have started a child development center, which is right now targeting babies from 0 to 2 and trying to see if there are any problems which the parents, there may be subtle parents which the problems which the parents may not recognize or they may not be able to recognize, which the doctor picks up and then, kind of starts to kind of work with some therapy and brings up the child and makes it, if there are problems, small problems, those problems disappear.
Okay.
And
in which areas?
all the areas, all fields of medicine,
Really?
apart from other fields also, I think. But then definitely they're trying to see what the quality of the egg is, whether the quality of the egg can predict the quality of the embryo, whether these embryos that are, like he was talking about the time-lapse system, which we saw the video of that embryo growing. So on day 5, the time-lapse system itself, looking at the morphokinetics, that is the shape of the embryo and the way it has followed its timetable, meeting certain timelines correctly. Whether these embryos are going to be genetically normal, so can that system predict, can AI predict, looking at the morphokinetics, can it predict the genetic normality of that embryo, looking at trying to find which is the best sperm to select to put into the egg.
That was such a fascinating discussion with Dr. Devika Gunasheela and Dr. Rajsekhar Nayak. I hope all of you enjoyed it as much as I did. I learned a lot today. And this is the first of the Times conversations that we are having in Bangalore. We hope to have many more in the coming times, and I hope you will be there to listen to all of them again. Thank you all once again. This is Sujit John signing out.